Nighthouse is dedicated to promoting reading success for all. We attack illiteracy from 3 angles.
Good job.
We give teachers evidence-based strategies to teach reading. We provide parents of struggling readers with support and information. And we teach adults to read.
Giving the kids the Nighthouse strategies and letting them know that they can compete with anyone, that's our passion.
I know that the work that my teachers are investing in daily is working, and it's having a greater impact, not just on the students themselves, but with their families, with our community, with our city.
Hello, everyone. I'm Dr. Tracy Wheaton, President and CEO of Nighthouse Education Center. Welcome, and thank you for joining us today. Nighthouse Education Center has been changing lives for more than 40 years. We provide evidence-based professional development to educators, information resources to parents, and direct services to adult learners. Nighthouse strives to be the leading nonprofit for building knowledge in the science of reading, an evidence-based approach that improves reading success for all. It is essential for those with reading disabilities, including dyslexia. On behalf of the Board of Trustees, the Advisory Board, and our staff, thank you for joining us. This annual event honors Lenox M. Reed, our founding director who led the center for over 20 years. Lenox continues to serve a vital role serving on our advisory board, our alumni council, and our lifetime trustees. Much of the center's success can be attributed to Lenox's vision, wisdom, and dedication. We would like to extend our gratitude to Graham and Edward Nighthouse, the sponsors of today's event. If you wish to receive a certificate of attendance, ALTA or Texas SPEC CEU credit, you will have an opportunity to download your certificate at the end of this presentation. Once the presentation has ended, please click the certificate icon in the certificate of attendance box on your dashboard. For those of you who are joining us live today, April 15th, please use the chat feature to submit any questions during the presentation. Dr. Gaab will have an opportunity to address these questions at the end of this seminar. Now it is my honor to introduce to you Dr. Nadine Gaab. Nadine is an associate professor of education at the Harvard University Graduate School of Education. Nadine's work focuses on developmental cognitive neuroscience, particularly in language-based learning disabilities. Her research in the Gaab Lab examines the development of typical and atypical language and literacy skills in the pediatric brain, and premarkers of learning disabilities, and the development of screening tools for screening literacy milestones and dyslexia. She is the 2019 recipient of the Learning Disabilities Association America Award for her work on learning disabilities. She also received the Allan C. Crocker Award for her advocacy on behalf of children with dyslexia and reading disabilities and efforts around the passage of the Massachusetts screening legislation. She has also been recognized by the International Dyslexia Association in her receipt of the Norman Geschwind Memorial Lecture 2020 and the Allan H. Garside Award for outstanding leadership in advancing the science and advocacy of dyslexia.
Welcome. My name is Nadine Gaab, and I'm an associate professor of education at the Harvard Graduate School of Education. I'm very honored to be this year's speaker, and I will be talking about screening for early literacy milestones and disabilities, the why, when, who, how, and where. So let's start with the why. Learning trajectories are shaped by the dynamic interplay between nature and nurture, which starts as early as in utero and continues throughout our lifespan. Learning differences are often not identified until childhood or adolescence or even later, but diverging trajectories of brain development may be present as early as in utero, so prenatally. Learning to read is not a natural process. Learning to read requires the mastering of a series of developmental stages in response to input from the environment. It starts with sound processing or language processing in utero and ends with proficient reading many years later. Learning a language is very different from reading in that sense that if you immerse a child in a rich language environment, they almost automatically learn a lot of the aspects of language. However, if you would, lock an infant into a library and get him out 6 years later, they would not miraculously appear as, good and confident readers. No, because it requires explicit instruction. It's more like learning a musical instrument where you listening to Mozart all your life doesn't mean that when you sit in front of the piano, you can then play as well as Mozart. It's an explicitly taught skill. So it needs input and explicit instruction in order to develop. So when you ask people, when does typical reading development start? You get a variety of answers. Some say, oh, it starts the first day of kindergarten. It may start the first day of preschool. Some say, well, if the caregiver starts introducing letters early, maybe it starts at age 2. But if you think fundamental milestones of learning to read are sound and language processing, and that starts as early as in utero. After that, after the child is born, visual processing is very important in order to then map the sounds of the language onto the written counterparts. We also need to learn to manipulate the sounds of language, what we call phonological processing or phonological awareness. And we need to be able to then decode and map these sounds onto letter combinations, read single words, read connected text, and ultimately the goal is to read with high automaticity, fluently, and comprehending what you read. So there's a series of milestones and a series of very important steps from different domains, and they all need to be integrated to a coherent reading network. It's also important that there is a shift in the US from learning to read to reading to learn, which usually starts or happens around the end of second, beginning of third grade. This is when elementary school teachers stop actively teaching how to read, and instead they use reading as a tool to convey knowledge and to have children access the curriculum. This is a very famous slide by Hollis Scarborough. And it's a really important slide because it shows that in order to become a skilled reader, there's 2 big buckets that are important. One is what I call the mechanics of reading, right? It's the word recognition piece. So you need the ability to manipulate the sounds of language. You need to be able to map these sounds of language, so decoding, the spelling sound correspondence, the alphabetic principle, as well as being able to read sight words. This becomes increasingly automatic, and you can see how these individual strengths are woven together. However, you could be the best reader or best decoder. If you don't know the words that you are decoding, that will influence your reading fluency and your reading comprehension. right? So if you start with problems in the language domain, so vocabulary, or you have problems with the syntax of language, and that could be because you have delayed language development or due to the input you got in your environment. That can then lead to problems with especially reading comprehension and reading fluency, because language comprehension becomes increasingly strategic. And these two components also interact closely with each other to then a skilled reading network. The development of basic reading skills is one of the primary goals of elementary education. 65% of fourth graders are reading below grade level in the US, and approximately 80% of those from low socioeconomic backgrounds read below grade level. Difficulty reading at grade level can lead to a variety of negative outcomes. Low self-esteem can be observed as early as in kindergarten, right? So you used to be the king on the playground, running the fastest, climbing the highest, and then suddenly you start kindergarten and all your peers somehow can map these sounds that you heard all your life onto the written scribbles, but you are unable to do this. And so that can really affect your self-esteem. It can lead to feelings of shame, inadequacy, helplessness. And struggling readers are at a higher risk for developing internalizing or externalizing behaviors such as depression, anxiety. There's higher risk for suicide, as well as higher risk for aggressive behaviors, because you're simply frustrated and you can't figure this out. Struggling readers, when they grow up and become adolescents, and are diagnosed or not diagnosed with a learning disability, are less likely to complete high school or enroll in any post-secondary educational programs. And we know that it also has tremendous implication for your vocational and economic, as well as your health outcomes. If you struggle with learning to read, it affects your motivation to read. It affects your motivation to learn. It affects how you see yourself as a learner. Learning to read is somewhat your first job. So if you fail at this first job you have in kindergarten and first grade, that has tremendous implication for your mental health and your overall outcomes. 70% of below average readers in first grade remain below average readers in 8th grade. Children with reading difficulties in 3rd grade are likely to struggle throughout their entire educational career. Struggling readers are 4 times more likely to drop out of school, and African American and Latinx children who are struggling readers are twice as likely as their white peers to drop out of high school. Drop out before high school. So how does reading improve learning, or how is reading related to learning? On average, kindergartners start their first day of kindergarten with about 10,000 words that they know. So they know the meaning of 10,000 words. And these are learned through their caregivers, their preschool. The bad words are learned through their siblings. I can see that in my house. I have 3 small children. And by 5th grade, proficient readers have about a vocabulary of 60,000 words. That's an increase by around 250 words per week. So where does this come from? And it's, just reading. It doesn't have to, be reading Harry Potter. It can just be, reading like the magazine at the doctor's office, the ad at the bus stop, any, instruction for your video game, etc. So it has been shown that a lot of this vocabulary increase is related to the proficiency in reading. So what are the literacy experiences for poor readers? So we do know that if you're a poor reader, that you read less at home, and that can have tremendous implication for your background knowledge, for your vocabulary knowledge, for your development of syntactic knowledge, etc. What are the factors contributing to atypical reading development? We have genetics, we have the brain, we have perception and cognition, and we have the environment. We see reading disability as an umbrella. Dyslexia is definitely under the umbrella. We'll talk about what that actually means to have a diagnosis of dyslexia or having problems with the mechanics of reading. But you can also have reading difficulties as a result of environmental circumstances. So if you only hear, a certain set of vocabulary words in your home, that's all the words you know when you start reading. So that can really influence your reading comprehension, as well as, syntactic knowledge. So if your family only speaks in very short sentences, or the sentences are incorrect because maybe of English language learners in the household, that can lead to you not being able to know how the end of a sentence relates to the beginning of a sentence when you read. So it can really have implications for reading comprehension. So what is developmental dyslexia? It affects about 7 to 10% of children, and it's a specific learning disability with a neurobiological origin, and it's characterized by difficulties with accurate and or fluent word reading. Okay, you can also have problems with spelling and decoding abilities. And secondary consequences are definitely reading fluency problems and deficits in reading comprehension. But the core deficit is on the word level. It's on the decoding side. It's on the mechanic side. So if you look at the reading rope here in the bottom again, bottom right, it's the lower part of that reading rope that children with dyslexia, individuals with dyslexia, are struggling with initially. So what is the typical reading network with its key components? So we have about 4 key components. It doesn't mean that the brain only uses these 4 regions to do, reading, but it's the, some of the key components in the left hemisphere of the brain. So in red, we have what we call the letterbox of the brain. This term comes from Stanislav Dehaene, and it's an interesting area that develops in response to the environment teaching you letters, and it recognizes letters and words. And in orange and green, you see typical language regions in the brain. And so initially you have a triangle that enables you to map the letters onto the sounds and the sounds onto the letters, right? And it's really important that you do this early on because it builds this really strong, back part of the reading network. In purple here, you have inferior frontal regions, we call them, or we can also say the CEO of the reading network, because that comes on board a little bit later, and it's really related to automaticity, but also reading comprehension. So eventually you need to have communication between all of these areas, but initially you have a triangle between these back regions, which then need to be connected to the CEO, because you need reading fluency and reading comprehension as well. So how do these brain regions actually talk to each other? And we have long axons, almost like highways, that are connecting different brain areas. And you can see them here on the right. So a very prominent one is here in red, the arcuate fasciculus, and it's named because of its shape. And it connects, for instance, the back of that reading network we earlier discussed to the CEO of the reading network. And so I want to show you a video of an adult reading a couple of words. And with the knowledge you just got the last couple minutes, you may be able to see what's going on in this brain. So most people are really surprised how many different brain areas are active. But what I want you to look at is the sequence. So you can see that it starts in the visual areas in the back and then goes into this triangle that we discussed earlier and then connects to the frontal areas here, the CEO of the brain. And this network is surprisingly universal for different languages. So there's not a lot of differences if you look, for instance, at Spanish, English, Hebrew, and Chinese, or I think Mandarin they did here. So what are what are the structural and functional, so brain structure and brain function differences in struggling readers? So research could show that there's fewer neurons in these brain areas we discussed earlier in struggling readers compared to their peers. There's also differences in these long-ranging highways. So we are not quite sure yet what the nature of the differences is, but it could be that instead of 4 lanes, the highway only has 2 lanes. Or instead of having a really smooth surface, could be a really bumpy surface because the myelin that makes the information flow go fast maybe develop differently. Or it could be that it doesn't really look like an arc, it's all disorganized, almost like having a lot of crossing streets or traffic lights on your highway. We also know that if you have a co-occurrence of ADHD in addition to dyslexia, that some of these brain areas look very similar. But interestingly, it's not that your brain just looks like, a brain of a child with ADHD and on top a brain of a child with dyslexia. There's some unique areas that seem fundamentally different. And so I think it's really important in the future for us to see, are there any unique intervention strategies we need to develop for kids who have problems with ADHD as well as dyslexia? So for the longest time, it was unclear whether these brain alterations I introduced to you earlier are the result of failing on a daily basis, or do they predate the onset of reading instruction? And that has important implications for policy, right? Because if a child already starts the first day of kindergarten with a less optimal brain for learning to read, we need to find them earlier. We need to find them before they start kindergarten. Right? And so that's what we could show, and not just us, others as well, over the last 15 years, is that there are certain brain alterations that are there the first day of kindergarten. So these kids step with their little backpacks into the first day of kindergarten with a less optimal brain for learning to read. So don't wait till 3rd grade or the end of 2nd grade and say, oh, it's just a summer baby. Oh, he's just slow developing. Oh, she will catch up. If it's really dyslexia, then you need to find these kids early and intervene early. If you look cross-sectionally, so that means if you look at this arcuate fasciculus that we discussed earlier, you can see that certain parts of that arcuate fasciculus are different in kids who have a strong familiar risk compared to kids who don't, as early as pre-readers. And that's quite interesting because we know that if you have an older sibling with dyslexia, you have about a 40 to 60% chance to develop dyslexia yourself. And so this gives you a really strong risk. And we could show that, you can already see brain alterations in kids, and that these brain alterations also lead to a slower development rate in these kids who subsequently develop poor reading skills compared to the ones who develop good reading skills. But the question still is, are these kids actually born with these brain alterations, or do these brain alterations develop in response to the environment, right? So it could be atypical language development or something that happens in the environment in terms of input into the brain that leads to the brain being different prior to the first day of kindergarten. And if you look at this here, at the x-axis, you see age, and at the y-axis, you see change of different brain tissues. And you can see that most of these important brain tissues, like gray matter and white matter, we just discussed, these highways, have their biggest change in the first 2 to 3 years of life. So this is an area we really need to look at. We really need to understand, how does atypical reading develop prior to these kids stepping into the first day of kindergarten, and moving away from just thinking reading starts the first day we get formal instruction. And we've been doing this over several years now. We've putting infants into a brain camera. So this is a very safe environment, no x-rays or anything. And what we do is we basically ask families to come in, and then we say, please put your baby to sleep. And they do this because babies always fall asleep when you tell them, right? And then they lie in the scanner for 2-3 hours and we look at their brain. No, it's actually really hard. And we have a series of wonderful baby whisperers who help us with this. And what we could show is that, and here you can actually see my daughter, who is now a 5th grader. So you can see how long we've been doing this. And we follow them once they sleep inside. And you can see that, for instance, this arcuate fasciculus here looks very different in the different babies. And we were interested, is it already different in kids who have a strong familiar risk, so you have a higher familiar risk to develop reading, and how does it develop over time? And we could show that there's already atypical segments of that arcuate fasciculus in babies who have a strong familiar risk. And so if you look at where these differences are, you can see that they're in similar segments in infants, pre-readers, beginning readers, and fluent readers. What we then did is we followed them over time. And we could show that in the left hemisphere, for instance, this arcuate fasciculus is associated with phonological awareness, vocabulary knowledge, and also decoding a couple of years later once they are in kindergarten. So that suggests that at least some of these brain alterations are there and different in children who subsequently have problems with learning to read as early as in infancy. So when should we screen, and whom should we screen? So we had a series of key policies and awareness milestones since 2000. So we have the National Reading Panel and No Child Left Behind and Decoding Dyslexia and Emily Henford's excellent journalism. But if you look at the nation's report card, there hasn't been many changes since 1992, right? So these are the 65% of children that are who are reading below grade level that I introduced you to earlier. This is proficiency here at the 240 mark. These kids are on average below proficiency. And the important part of the slide is it hasn't changed. So all of these key policies have not moved the needle. So we need to start thinking outside of the box. When it comes to learning differences, we are largely focused on a reactive, deficit-driven wait-to-fail model instead of the development of preventive approaches. We wait till a child shows up with a problem, and then we try to fix the problem, instead of finding the kids who most likely will have problems and helping them before they develop any problems. The dyslexia paradox describes that reading disabilities generally diagnosed after the most effective intervention window. So we have the current diagnosis and start of intensive intervention, which usually happens, after failure over a significant period of time. So the end of 2nd, beginning of 3rd grade. But we know that the window for the most effective intervention, it's actually in kindergarten and 1st grade. So there have been many studies now that looked at effect sizes, showing that intervention studies are reporting larger effect sizes in kindergarten and 1st grade than in 2nd and 3rd grades. So when at-risk beginning readers receive intensive instruction, 50 to 90% of at-risk children across 6 studies reach the range of average reading ability. So we can prevent reading problems by finding kids early and helping them early. So how can we do this? So we did a READ study with John Gabrieli at MIT many years ago, and we basically screened 1,500 incoming kindergartners and followed them over time. And we were really interested, are there any early reading profile? And so I'll give you a little anecdote. When we first started this 10 years ago, we walked into a large district very close to where we are located. And we said, hey, we are a group of researchers, and we would like to offer you to come to your district and scan and screen every incoming kindergarteners, and then, develop strategies with you how to address problems, and then follow these kids over time. And we were surprised how many said, no, we don't want you anywhere close to us. We don't want to shift resources from third grade to kindergarten, and the parents would all go crazy. And one administrator even said to me, these kids will still struggle in third grade. We can find them there. Then we don't have to look at it that early. Not thinking about the implication for reading motivation, for their self-esteem, for their overall outcome, not keeping these mental health implications in mind. So we found 6 distinct cognitive profiles, and the important part of this slide is that kids learn, have strengths and weaknesses, and you can see those as early as the beginning of kindergarten, and they remain stable. So if you screen them, you can identify the children who will struggle a couple years later. So how should we screen? Solving the dyslexia paradox. So what we need to do is we need to embrace what we do in medicine. In medicine, we embrace preventive medicine, right? So we screen for high cholesterol. And if you have high cholesterol, what we do is we don't tell you that you have a diagnosis of heart disease. No, what we tell you is that you have a heightened risk to develop heart disease, and that you need to make changes so that you will never develop heart disease. Okay, so that could be, changing your exercise and diet and getting medication, etc. The same idea we have, we promote for solving the dyslexia paradox. So we need comprehensive early risk screening in pre-K and K. Right? So we need to identify the children at risk. We're not diagnosing then, we're identifying children at risk. And then we need evidence-based response to screening within general education. So that requires a lot of good teacher training, which then ultimately doesn't overcrowd SPED, special ed. It leads to lower rates of dyslexia reading disability diagnosis, like in our example for preventive medicine. And if someone still gets a diagnosis, they still will have improved reading because intervention started so early. So why is it more effective to intervene early when it comes to reading? And there's at least 2 reasons. One is that the brain is a lot more plastic for language the younger it is. And secondly, is what we discussed earlier, that there is a gap often between poor readers and good readers that developed really quickly in terms of vocabulary knowledge, in terms of background knowledge, because you just read less if you're a poor reader. And in order to avoid this gap, you have to intervene early. So what are some of the early behavioral predictors of reading difficulties in dyslexia? Phonological awareness, pseudo-word repetition, rapid automatized naming, expressive receptive vocabulary, letter sound knowledge, and oral listening comprehension. So what you can see here is that you have that language piece here, and you have that mechanics piece, right? So you need both in order to identify all children who most likely will struggle with reading. And rapid automatized naming is really interesting here because it strongly predicts reading fluency. So this is the ability to quickly name a series of highly familiar objects or colors in reading direction from left to right and several rows. And it really taps into automaticity and retrieval. So what should early screening look like? We recommend 8 key characteristics. It should be short. We're not doing a neuropsych assessment. It needs to be comprehensive. Think about the reading rope. It needs to cover all the key elements. It could be resourceful. Sometimes school districts already have really good screeners in place that they use for older children that you can then, utilize for younger population. It has to be early. I hope I convinced you for this. Please include ESL and dialect speakers. We know that they have a higher risk of developing problems with reading and are often, overseen, overlooked because people say, oh, they have to learn English first, or they need to learn mainstream English first, and then their reading will improve. But they have the same prevalence, so maybe even higher, depending on their backgrounds. We need to include the genetics. So in your screening protocol, ask families, is there anyone in your families who were struggling with learning to read? And then ask further questions. Why? Was it because they didn't have good instruction, or was it because they may have been an undiagnosed underlying learning disability? Evidence-based response to screening. You can screen the whole world. If you don't do anything in response to it, it's useless, right? So you can screen everyone for high cholesterol. If you just lean back and don't do anything, it's completely useless. And it has to be developmentally appropriate. So don't screen for reading comprehension in the first 2 weeks of kindergarten. Screening for dyslexia is different from a diagnostic evaluation conducted to formally diagnose a child with dyslexia. Risk factors do not determine whether or not a child will have dyslexia, but rather represent a probability that a child will develop dyslexia. So it's really important that you know that there's a difference between diagnosis and screening. A screening test cannot tell you that a child will subsequently develop dyslexia. Rather, it determines the likelihood that a child will develop dyslexia. Phonological deficit. So we discussed the importance of phonological awareness, of phonological processing, and phonological deficits have been linked to subsequent word reading outcomes. However, not all children with a phonological deficit develop problems with word reading. Not all children with a word reading deficit show deficits in phonological processing. There's a general consensus now in the field that there's a multifactorial causal model, that there's many different pieces inside the child, but also in the environment that together cause problems with reading, and that these environmental and genetic factors interact with each other. So here's the cumulative risk and protective model. So there are risk factors as well as protective factors, and that was put forward by Katz and Yakov Petchers, which are wonderful researchers at the Florida Center for Reading Research. And this also illustrates this multifactorial idea, right? So you have risk factors and you have protective factors, and together these either tip the slide to one side or the other. The seesaw, not the slide. Okay, so back to the how. There's wonderful resources for you to decide which screener you should use in your school district. There's the National Center on Intensive Intervention, who has this wonderful chart here, and I show it to you. And I just picked, a screenshot. I'm not like promoting any of these screeners mentioned here, but it can show you all different screeners in the domain you want to screen. And it tells you all the psychometric properties that are really important, like how good is the screener to actually classify kids from, into good readers subsequently and poor readers. How good, how valid is it? Is it actually tested in children that match your population or not? Can it be used more than once? Has it been tested in a large group of kids, or is it just, poorly developed? And so it's really important that in order for you to decide and to pick an evidence-based screener. We also put together a list of all screeners out there. And this really helps you to determine if you see screener out there, how does it compare to others? What is its cost? How time intensive is it to administer it? Is it administered via computer or paper pencil? How much personnel do you need? What kind of components does it screen for, etc.? There's also wonderful resources on the National Center on Improving Literacy, like this Screening for Dyslexia handbook. And we developed a screener as well. And I'm a co-founder of the company, Early Bird Education, so I have a conflict of interest that I need to declare here. But what we did is we developed this in response to what we heard from teachers in the field. I do a lot of professional development sessions. So the teachers in the field told us, we don't have the time to screen. We don't really know how to screen. And once we screen, we don't know how to interpret the screening, and we don't know how to respond to it. And this is a screener that is an engaging game. It's self-administered. So you can just give it to the child and they play the game by himself or by herself, themselves. And it takes about 15 to 20 minutes. It's tablet-based. We also are moving it to a Chromebook right now. It has auto scoring. It's appropriate for pre-readers. It not only screens, but it also is giving you the interpretation. So who's at risk in which domain, and it gives you a rich platform of resources that enable you to decide, a good strategy for the evidence-based response to screening. So what should we do next? So if you're interested, you should check out the screener, but there's many, many different screeners out there. And you should really look at the National Center for Intensive Intervention to see which one fits your population. Some of the major early literacy milestones covered here are listed here, but they're in line of the research I just recommended. So does this approach work? Does this approach of preventive compared to a reactive model in education work? And there's been wonderful researchers like Louisa Moats and Hugh Katz who have worked on this over many, many years. And this here is a really interesting study that looked at early screening and see whether it can identify good and poor readers at the end of first grade. And it really illustrates that this approach has a really high potential to move the needle and hopefully change our flat line of the, in terms of reading scores in this country. There's been a lot of legislation also out there, like from here again, the National Center on Improving Literacy provides this map here where you can click around and look for your state, whether there's pre-screening, pre-surface, in-surface, or intervention legislation. And you can also read up this legislation. But we've come a long way. I'm confident that this will hopefully lead to, an increase in good readers in the United States and beyond. So what are the challenges with the screening legislation? What are we actually screening for? Are we screening for word reading? Are we screening for reading comprehension? What are we screening for? It's really important to clarify this. What are the costs of screening and who pays for it? And there is this general perception that screening will lead to overcrowded special education, but it's actually opposite, as I explained earlier. Screening will actually lead to less overcrowded SPED, right? Because you identify children early and you address it early when the problem is really tiny. And so the ultimate goal is that these kids never enter special education. Which kind of screeners should I select, and what kind of guidelines are out there? Also, often there is no data literate personnel in the school. So who's actually interpreting the screening outcome, and who establishes the screening protocol, and who helps with these kinds of decisions? So what are the important factors to consider for selecting the right screener? Sensitivity. So how good is the screener in correctly identifying those who will develop a reading disability, and specificity, so correctly identifying those who will not develop a reading disability. And you can use the National Center for Intensive Intervention tools chart to determine the sensitivity and specificity, and also look on the technical manuals. Classification accuracy is really important. The resources in the school district. So how many resources do you have in terms of personnel and data literacy personnel, data literate personnel, in order to develop the screening protocol and disseminate and implement it? The quality and quantity of early intervention is really important. Your student population, you want to pick a screener that fits your student population. So if you think that your student population is primarily struggling with the mechanics, you need to pick a screener that, for sure screens for this. The other way around, if you think that your student population will struggle a lot with the language piece, you need to have a screener who has this as part of their strategy as well. And in order for you to learn more about these psychometric properties, like reliability and validity and what actually is classification accuracy, etc., you can go to the National Center for Improving Literacy and look at these wonderful briefs that you can also use as infographics for parents and teacher training. So other factors that are really important is that screeners should directly measure the child's ability. So there has been screeners out there now who claim that just asking a couple of questions to the teachers or parents will be as good as actually measuring the child. This is really dangerous because it can lead to implicit biases or explicit biases. So you may think that, oh, this child who just started in my classroom comes from a really, educated background and a really prominent preschool. And if someone asks you, does this child know all the letters? And you haven't really tested this, but you said, well, I think yes. So you may have this implicit bias, and it can go the other way around for a child where you think, oh, maybe they don't know all their letters, but they actually do. So it's really important to directly measure the child. The screening approach needs to consider the family history and environment of the child, right? So it needs to also match your population. There needs to be a plan for implementation that involves all stakeholders. So I do not recommend that you just dump the screener onto your, schools or your, a teaching team. All stakeholders, including bottom up, including parents, need to understand that screening is different from diagnostic evaluation. The tool should be culturally and linguistically appropriate for the population to be screened. It's important to keep in mind that children can be screened for the risk of developing dyslexia multiple times over the time course of literacy development. And the approach needs to contain a detailed plan for the next steps. And most importantly, screeners are not perfect. So don't get frustrated if you may have a miss or false alarm. Just, tweak your approach, address it. So we all are affected by closures and restrictions and health issues related to COVID-19. High rates of infection and mortality from the COVID-19 pandemic have led to the sudden closure of educational institutions in approximately 200 countries, affecting over 90% of students. COVID-19 related school closures have been proposed to be viewed through the lens of learning loss usually observed during the summer month, right? But it's unclear whether these two types of seasonal school closures are leading to similar learning losses. However, what we do know is that children from lower socioeconomic backgrounds and children with learning disabilities both show larger declines than their high socioeconomic status peers and typical learners during the summer month. And they may therefore be most affected by COVID-19 school closures. What are the important things to consider? COVID-19 inflicted trauma in the house. There may be a death in the family. There may have been more abuse. Home literacy and practices that may have changed because parents are, stressed, maybe working more, maybe working less. COVID-19's restrictions and school closures, assessment and screening and progress monitoring capabilities in the schools, and the quality and quantity of remote instruction the child got, and whether they had access to technology or not. So also keep these environmental risk factors in mind that we know affect poor literacy can lead to a poor literacy outcome. So child neglect, abuse, and adversity, stress in the house, but also stress related to immigration status, language spoken at home, the home literacy, trauma, caregivers' education, poverty and socioeconomic status, and the neighborhood factors and the learning environment in the school and at home for the child. So where should we screen? We have been working hard to push pediatricians to also do screening at the 4 and 5 year well visits. They don't like that idea very much. They say, well, we currently screen for ADHD and autism because these developmental disabilities require medical interventions. And so therefore we should screen for those. Learning disabilities, on the other hand, require educational interventions, and therefore we shouldn't screen for it as pediatricians. However, we disagree with them because we think that the impact on mental health and the impact on self-esteem and the high rates of anxiety and depression and increased suicide rates are really important and should therefore lead to screening in pediatricians, or should be an important reason that we need this. And we're working right now with several other groups on developing very short screeners for the pediatric offices. The other thing I want to highlight on this list are libraries. The idea to screen in public libraries, and we did one pilot in Chicago public libraries, where the idea is to offer these screening weekends or screening days, and then link the screening results to the library cards and make recommendations of books that caregivers could bring home and read to their children. And in order to start with advocating for screening in pediatricians' offices, we wrote this paper, and I recommend you download it and read it and bring it to your pediatrician. To conclude, the development of reading proficiency is a public health issue. Literacy is a widely recognized determinant of health outcomes and is associated with many indices of academic, social, vocational, and economic success. The National Academy of Medicine recently summarizes that the duration of education, which is highly dependent on reading proficiency, is a very strong predictor of health and longevity. Similar or along the lines with smoking and obesity. So let's work all together to maximize the joy of learning to read, because every child has the right to learn to read well. I thank you very much for listening, and let me know if you have any questions.
Thank you, Nadine. It has been a pleasure having you with us today. Again, for those attending today's seminar for a certificate of attendance, ALTA or Texas SBEC CEU credit, please click the certificate icon in the certificate of attendance box on your dashboard. Thank you again to our sponsors and the incredible educators who have been present today for the 2021 Lenox M. Reed Seminar. We are so grateful to all of you. It is now time to transition to our Q&A session that will be audio only. Please listen to Dr. Gaab address some of the questions that were submitted during the presentation. Thank you.